Okay, hi, can anyone hear me? Someone mind just popping a message in the chat, just to check. Perfect, thanks very much. Right, so it's just gone 6 o'clock. I think we'll make a start there. So to everyone who's just arrived, thanks very much for coming. I'm Dan. I'm one of the F1s in the Northwest region in Liverpool. Today, we're going to be running our series on HPB as part of the Mind The Bleep final year series. So hopefully we'll get some good revision in. I'm going to be presenting this one, but my colleague Sarah also made a few of the slides. And just started recording as well, if that's all right. We've got some SBAs questions coming up as well, so we'll get some polls going for that. So let's get started. So aims of this session cover some of the common HPB presentations and conditions based off the UK MLA curriculum. We've got some SBAs, as I've just said, to try and aid your revision. Recognition, so presentations, initial exam, investigations, management of these conditions, and your role as an F1. And I'm actually on a Gen Surge placement right now, so it's worked out quite well. It's quite convenient. Okay, so based off the UK MLA content map, here are some of the things we're going to cover. So all the gallstones and the cholecystitis, the biliary pathology, pancreatitis, a couple of the cancers as well, and then the presentation. So things like abdominal pain, jaundice, change in stool colour, nausea and vomiting. Right, so we'll start with the first question then. 40-year-old woman called Gabby Alston comes into the emergency department with sharp right upper quadrant pain, nausea, and it came on after eating her Christmas dinner. On examination, she has a large body habitus, she's afebrile, and the pain settles quickly with analgesia. So what's the most likely to be raised on blood tests? And if I just start the poll there. I'll give you probably about 20, 30 seconds just to answer. And by the way, if anyone has any questions, just feel free to pop a message in the chat. I can see it as well, so not a problem at all. All right, so about 10 more seconds. If you don't know, just have a guess. Doesn't really matter. All right. So, if the thinly veiled pun of her name didn't give it away, this is a typical presentation for gallstones. So simple biliary colic. So Gabby Alston, gallstone. So if we go to the next slide, you can see the answers ALP. And so why is this gallstones? Well, it's the typical kind of demographic. It's a 40s lady, large body habitus. It's got none of the features of cholecystitis or cholangitis. So it's she's afebrile. Most likely the inflammatory markers will be normal. And it's exacerbated by having a fatty meal, aka the Christmas dinner, and it settles quite quickly with analgesia. So why is ALP raised? Well, usually with biliary colic and biliary pathology, you get a cholestatic picture on the LFTs. So the GGT and the ALP will typically shoot up. You only really get raised ALT when it involves the liver and the actual hepatocytes, and that's a bit more concerning. But usually in just normal biliary colic, your ALT will most likely be normal. In terms of bilirubin, so that's related to jaundice. You usually get that if something's actually physically blocking the passage of bile through the bile ducts. So you might see that if there's a stone in the common bile duct, but not necessarily if you just have gallstones in the gallbladder. Amylase is related to pancreatitis. We'll come on to that in a bit. and albumin is well, it'd probably be normal, to be honest, but if in acute inflammation or malnutrition, it's lowered, so it wouldn't be raised really. Okay, so let's get on to gallstones. So gallstones are very common, especially in Western society. About 10 to 15% of Westerners have gallstones, and most of the time they're asymptomatic. So in the vast majority, the people won't have symptoms with them, and that's great because then you don't need to investigate them or treat them. Only between 1 and 4% actually get symptoms. So what are they made of? Well, most of the time they're made from either cholesterol or mixed cholesterol and pigment. Okay, and that's related to the whole large body habitus, fatty foods kind of picture. In terms of pigment stones, you see those with conditions like hemolysis or hemolytic anemia. So when the red blood cells get broken down, because then the hemoglobin gets turned into bilirubin, and those can form bile pigment stones if you have too much of that. So the key risk factors, the 5 Fs: female, fat, fair, 40, fertile. Not to be confused with the 5 Fs of abdominal distension: fat, fluid, flatus, feces, and fetus. Also hormonal causes or risk factors, so the pill, COCP, pregnancy, bile malabsorption can also increase your risk of pigment stones. So if you have Crohn's, for example, it's inflammation of the terminal ileum. So the end of the ileum is one of the key places where you actually absorb bile salts. So if it's inflamed or you have a terminal ileal resection, you won't absorb bile salts as well, and that can also predispose you to pigment stones. And as we've talked about, hemolytic anemia, so the breakdown of the red blood cells. So more hemoglobin gets broken down to bilirubin, and bile pigments increases your chance of getting stones. Then here, just in this little box in the top right, we've got a few of the key terms and definitions. Sometimes people can get confused between, I think probably the main ones, cholelithiasis and choledocholithiasis. So just to clarify, choledocholithiasis specifically refers to stones in the common bile duct or the CBD, rather than in the gallbladder, which is cholelithiasis. And then another one's cholecystotomy, which is insertion of a drain into the gallbladder, which you might see in someone with a gallbladder empyema, so a collection of pus in the gallbladder, or in someone who's not necessarily fit for a full cholecystectomy. And gallstones, as we can see in this sort of diagram, can cause biliary colic, they can cause cholecystitis, cholangitis, and pancreatitis, and we'll come on to all of those. But it's a problematic little thing, the humble gallstone. So clinical features, well, you have the classic sharp, colicky right upper quadrant pain related to fatty food. Does anyone know why fatty food causes that classic colicky pain? If you know it, just pop it in the chat, or just take a guess. So it's related to cholecystokinin. Yeah, that's right. Yeah, Sohaib, I pronounced that right. So yeah, fatty acids from fatty food stimulate release of cholecystokinin from eye cells in the duodenum, which then causes contraction of the gallbladder. And if you have a stone impacting at the neck, blocking it off, then it's contracting against a blockage, which causes that classic colicky pain. You might also see nausea and vomiting. And the key difference from cholecystitis is the lack of an inflammatory response. So systemically, these patients are well. Their inflammatory markers, so the white cells, CRP is normal. They won't have a fever. The pain will be intermittent rather than constant. It will settle with analgesia related to fatty food, as I've talked about. And in cholecystitis, you'll see the Murphy sign, which we'll also come on to in a little bit. So the key investigations, it's always good, especially if you're in an OSCE situation, to try and structure things like investigations into stratify it into bedside, blood, imaging, more specialized investigations. So always start with the simple things like bedside tests, pregnancy tests, good test in any acute abdominal pain in a woman to rule out pregnancy. Urinalysis as well, so checking for UTI. Bloods, your simple full blood count, UGNEs, CRP, LFTs. Again, we've talked about. You might get a cholestatic picture, but they can also be normal. I've seen a patient this week with gallstones who've had completely normal bloods, so sometimes it's normal. Imaging, so first protocol is usually an ultrasound. It's very accessible, it's easy to do, it doesn't have radiation, it's cheap, and depending on that, then you might get some more detailed imaging with an MRCP. And usually, so you won't do that on everyone, it's quite selective. It's a very good image, it's very detailed, but it takes a while. It has to get vetted by a consultant, at least where I'm working. But it gives you a much more detailed image. And reasons why you might want that is if you, for example, on the ultrasound, if you see the common bile ducts dilated, so then you want better imaging to look to see if there's a stone in the common bile ducts, which isn't always so easy to see on ultrasound. Or if the LFTs are really deranged, you might want a better look with the MRCP. So that's a bit further down the line. Sometimes you might also get a CT. You might see people ordering CTs if you're not really sure of the cause. It's just a good kind of, it's like a surgeon's best friend, really. They love ordering CTs as just a starting line because it gives you so much information. Occasionally, probably less often, you might see an EUS, which is an endoscopic ultrasound. So you put a scope down the esophagus, the stomach, and the duodenum with an ultrasound probe, which can give you some pretty good information. I think it's probably used a bit less these days because MRCP is non-invasive, obviously, and it provides really detailed imaging. But good to bear in mind. So I've got a note here. So according to NICE guidelines, consider MRCP if the ultrasound is as detected common bile duct stones, but the duct is dilated. So that's more than 6 millimeters in diameter, although it can also increase a bit with age. And if the liver function tests are abnormal. Okay, management is basically conservative in the acute phase. So just treating the pain, simple things like IV fluids, analgesia, antiemetics, and giving them some lifestyle advice. So, avoiding fatty foods. And that's another good tip in OSCEs as well. If you asked about the management, stratify things in terms of conservative and supportive treatments first, and then some more definitive treatments. So the definitive treatment will be an elective laparoscopic cholecystectomy, so taking it out, removing the cause. That will typically be done a few weeks down the line. And if you find any bile duct stones on investigations or during the operation, then it's a good idea to clear those as well. Okie dokie. Let's move on to the next slide. So next question then. 32-year-old man, cholecystitis, presents with constant right upper quadrant pain, fever, nausea and vomiting. He has a history of gallstones but has not had surgery yet. He has raised inflammatory markers. He's not jaundiced, but he's Murphy's positive on examination. So what's the most appropriate first line imaging in this patient? And I'll just put the poll up there. So again, I'll give you between 20 and 30 seconds. And yeah, I probably gave away the answer in the last couple of slides, but yeah. The poll is also just completely anonymous, so don't worry about getting the answer wrong. I can't really see anyway, like who it is. Okay, so answer is ultrasound abdomen. It's just if you get a question that's asking for the first line investigation, imaging wise, it's a lot of the time it's ultrasound. It's just it's a good one. Again, another thinly veiled, terrible pun, cholecystitis. So this is cholecystitis. Why is it cholecystitis as opposed to biliary colic? So the pain's constant, the right upper quadrant pain's constant. It's Murphy's positive. He has a fever. He has raised inflammatory markers. He's not jaundiced, so we're not thinking of cholangitis just yet as the most likely thing. So as I explained earlier, ultrasound abdomen's a really good first investigation because it lets you see the gallbladder, any stones in the gallbladder, and especially if that's your main differential. It doesn't have radiation, simple, easy to do. Again, you might consider MRCP a bit further down the line if you need to look in more detail. And ERCP is not an imaging modality; it's an intervention. Okay, so acute cholecystitis then. It's an inflammation of the gallbladder. So presents similarly to biliary colic, but as we've discussed with the question, you get those features of being systemically unwell. So the fever, the raised inflammatory markers, so the raised white cells and CRP, the constant rather than the intermittent colicky right upper quadrant pain. And also just watch out for features of sepsis. So sometimes, in rare cases, they might have a perforated gallbladder, which can cause, more a worse infection. So look out for the hemodynamic instability. So the low blood pressure and the tachycardia, signs of peripheral shutdown. On examination, you'll see the right upper quadrant tenderness. You might see some guarding as well, so tensing of their abdomen. If someone's frankly peritonitic, they'll have that, classic hard wooden board abdomen. Or they might have some localized peritonism, so hardening, tensing of the muscles, just in the right upper quadrant, and the Murphy's sign. So does anyone know what exactly the Murphy's sign is? If you just want to quickly pop it in the chat. Okay, so the what you want to do is, so pain on inspiration, that's it's kind of that. So while you have them flat on the bed and you're doing your abdominal examination, you ask them to inspire, so to breathe in, and then when you're pressing down just over their gallbladder, it's a Murphy's positive sign if it kind of halts their inspiration because of the pain. So if they're breathing in and you press down and they kind of stop their inspiration. So that's Murphy's positive, and that leads you towards a diagnosis of cholecystitis. So investigations, as we've talked about, always try and stratify these into bedside, bloods, imaging, and then further kind of more invasive tests if you need. So bedside, we've talked about those already. That's, same things. Pregnancy test urinalysis, maybe an ECG if they're tachycardic as well. Bloods, yeah. So same as last time. FBCUs and E's, CRP, LFTs again. There might be cholestatic, so the raised ALP and GGT. Probably want to take an amylase as well to rule out pancreatitis. It's just a common add-on to any set of bloods you do with abdominal pain. Imaging, we've already talked about all of these. So next few slides, we're just going to go over a few. We're going to go over these images here in a bit more detail. I've got these off Radiopedia, which is a really good site for just if you want to see any radiological scans, and they have a really sort of generous policy in letting people use it for educational purposes. Okay, so this is an ultrasound. So you can see here it's a pear-shaped sort of organ. You can see the stones actually inside there near the neck, and those areas of opacity. And also, so what kind of things you're looking for on ultrasound is stones, obviously, but also gallbladder wall thickening, which indicates inflammation, or any fluid collections around the gallbladder, any fat stranding, which indicates inflammation as well. And one of the things you can do is it's called the sonographic Murphy's sign. So that's when you can use the ultrasound probe to see that the point of maximal tenderness is directly over the gallbladder when you're pressing down. And it's just the radiological correlate of the clinical Murphy's sign. This is a CT, so a coronal section CT. And as the report says on the right here, you can see that there's wall thickening, so mural thickening. There aren't any gallstones, so it's acalculous, and there's an incidental hepatic cyst at the top of the liver. And then this is an MRCP, so MRI of looking at the liver and the gallbladder. You can see quite nicely those stones there. There's a bunch of stones just outlined there. So again, on the report, you can see there's thickness of the wall. So try and have a look at that in the image. Mural thickness, some fat stranding as well, so it indicates inflammation. But yeah, that's quite a nice picture. Also, the CBD's dilated on this. You can see in the report it says it's 11 millimeters. Remember, it's usually less than 6 millimeters in diameter, the CBD. But again, it slightly increases with age. So if you see someone who's like 80 with a 7 or 8 millimeter CBD, it could be normal. So management, quite similar to just biliary colic, except you're going to add in antibiotics. Typically, it'll be like Kef and Met, so cefuroxime IV and metronidazole orally. That covers the abdominal infections. But again, never forgetting things like analgesia, IV fluids, antiemetics, all the basic things, and also lifestyle advice as well. So reduce fatty food intake. And then moving on to the definitive treatment, again, it's surgery. So there's a couple of ways you can do this. There's this thing called a hot versus a cold lap chole. And hot's when you do it, pretty quickly, immediately. NICE recommend doing it within a week if you're going to, within a week of symptom onset or presentation, if you're going to do it in the acute phase. But really, it should be probably within a few days. And that's because as the inflammation goes on over time, it can distort the anatomy, it can cause adhesions, and it can increase the likelihood of complications during the surgery. So if you can't get it in that window, or surgeon preference, whatever it is, then you can do a cold one where you treat them conservatively at the beginning in the acute phase, you give them antibiotics, and then you bring them back for an elective lap chole later on once everything's settled down. So you can do it either way. It's it kind of depends on local guidelines, surgeon preference, whether you've missed the window of opportunity. Alternatively, if they're not fit for surgery, you can do a cholecystotomy, so putting a drain in, or if they've got a gallbladder empyema. So we had a patient on the ward last week who had a gallbladder empyema. He'd been waiting a while to get his cholecystectomy and just ended up getting a drain in the end to relieve the pus in his gallbladder. But eventually those patients will also need a cholecystectomy afterwards. All right, question 3, moving on to the next one. 52-year-old woman complains of right upper quadrant abdo pain radiating to the epigastrium, also nausea and vomiting. She has sclerolicterus, she's tachycardic, she's hypotensive, and she's got a fever, temperature. She started on antibiotics. So which of the following is not true? So sorry about the negative question, but you do see them on exams. So okay, so the one that's not true is E. So you may know Charcot's triad is right upper quadrant pain, jaundice, and fever. Raynaud's pentad is basically just those three plus hypotension and confusion, so more features of sepsis really. So the key thing is I've put hypertension rather than hypotension, perhaps a little bit sneaky. But just going through all of the others. So yeah, just to clarify, this is cholangitis because you can use Charcot's triad to work that out. So common bile duct dilatation is often seen on imaging. So it's usually because the most common cause is gallstones, C, which cause obstruction, blockage, dilatation of the common bile duct. LFTs do show a cholestatic picture a lot of the time with elevated bilirubin because the bile is stuck there and it extravasates into the blood. And infection is often associated with E. coli. So E. coli, you might know, can cause UTIs. It's also a common cause of biliary infections. So it's good to know. No one likes micro questions, but that's probably one to remember: E. coli and biliary infections. Right. So acute cholangitis, inflammation or infection of the biliary tract due to obstruction. So that's really the key thing here. The obstructing, whatever it may be, stone in most cases, blocking the common bile duct. So there's a nice sort of diagram here on the right showing the different bit of the anatomy of the bile ducts. So at the top you've got the hepatic ducts coming from the liver, so the left and right hepatic ducts, and they come together to form the common hepatic duct. And then we've got the cystic duct coming from the gallbladder, which joins the common hepatic duct to form the common bile duct, so the CBD. And it's in the CBD where the blockage usually occurs. So what's the pathophysiology of it? So you get bile outflow obstruction and stasis. So let's say a gallstone has dropped from the gallbladder into the CBD and it's got lodged there. So the bile is obstructed and there's stasis. And then you get bacterial seeding and contamination. And I think that's theorized to come from the portal vein, which comes from the gut, and it runs in the, with the portal triad. You have the bile duct, the portal vein, and the hepatic artery. They're all close to each other. So you can get bacterial translocation into the common bile duct from the portal vein. Just got a question here: how to differentiate between cholangitis and cholecystitis? So the main thing really is the jaundice. So cholecystitis will have the right upper quadrant pain, fever, inflammatory markers. Clinically, the main differentiator is the jaundice and the raised bilirubin on bloods. And that will further be confirmed on imaging if you see a dilated common bile duct, because that means something's probably obstructing there. Okay. So you've got the blocked tube. You've got the bile sitting there. It forms a sludge. The pressure increases, and then eventually you get extravasation of the bacteria growing there, causing sepsis. So what are the causes? Well, gallstones we've mentioned is the most common, so that's intraluminal. You can have malignant causes, cholangiocarcinoma, or further down, pancreatic cancer, particularly around the ampulla in the pancreatic head. Sometimes it can be due to instrumentation, so ERCP or surgery. Other slightly less common causes, primary sclerosing cholangitis, so PSC, can cause stricturing, fibrosis, scarring, which can narrow the duct, again leading to obstruction. Sometimes pancreatitis as well, and rarely parasites. But I'd say gallstones, malignancy are probably the most likely ones. And so clinical features, as we've mentioned, jaundice is the main differentiator from cholecystitis. And you get that Charcot's triad. So if you see those three in a question stem, it's probably going to be cholangitis, plus hypertension, confusions, Raynaud's, pentad. And so we get the dark urine and the pale stool. Does anyone want to quickly hazard a guess at how that comes about? The pigment, so bile and bile salts cause pigment in your stool and your urine. So if you have a blockage in the bile ducts, then the bile can't get into the gut anymore, can't drain into the duodenum. So you don't get the stercobilinogen, right, in your stools, colouring it brown, so it goes pale, goes white. And because it's conjugated bilirubin, because it's after it's been conjugated in the liver, it's water soluble, so it goes into your urine and colours it dark. And it's not just like dark yellow; it's properly like Coca-Cola dark. So key things to ask if you see someone with jaundice and you're worried about post-hepatic jaundice, is to ask them about have they got dark urine, have they got pale stools. We actually had a guy a couple of weeks ago who he did have jaundice and he did have dark urine, but he also had dark stools. But we think that was because he drank like 20 pints of Guinness the night before. So yeah, there are confounding factors, but it's a good question to ask. And yeah, eventually, of course, it can lead to features of sepsis when you get the disseminated infection. So again, investigations, don't forget the bedside ones: ECG, pregnancy test, urinalysis, among others. Bloods, all the usual ones. You probably want to get a clotting and a group and save as well. Why? Because in cholangitis, one of the main interventions is ERCP, which is a slightly invasive procedure, so you're going to want to get a clotting screen before that as well. Perhaps a group and save, especially if they're anemic, to start off with. Going to get some blood cultures as well, so a key thing is to invest early on in that microbiological diagnosis, ideally before you've given them the antibiotics. But of course, if they're really ill, just give them the antibiotics. But try and get the cultures first. Blood gas as well. You can look at lactate. Do the whole sepsis 6. Imaging, abdo ultrasound is a good one. It can show, again, as we've talked about, CBD dilatation. So if you're suspecting some kind of obstructive jaundice and cholangitis, then it can confirm. It can confirm that with CBD dilatation. And again, similar further investigations you might consider, or your seniors might consider MRCP if there's diagnostic doubt, or to plan ERCP. You can maybe do an MRCP to have a better look at the anatomy, or to better see the common bile duct, and where exactly the obstruction is, where the stone is, or where the malignancy or lesion, whatever is. And so we've just got a couple of pictures here on the right of the ERCP, which is, I guess it's slightly on the wrong slide because it should be in management, but you can see they go through the stomach, round the first part of the duodenum, and partway down the second part of the duodenum. They go into the major papilla, so through the sphincter of Oddi, into the common hepatic duct, and they can remove stones. So it's both a diagnostic and a therapeutic intervention, ERCP. Speaking of, so management, the definitive management is ERCP, but again, not forgetting the conservative management to start off with. So you're going to do the sepsis 6 probably, because they have an infection going. So you're gonna take those blood cultures, take any other cultures you want to get, take the bloods, lactate, catheterize them, get the urine output and the fluid input output balance going. You're going to give them those antibiotics. If they need oxygen, you give them oxygen. Probably going to give them some IV fluids as well, analgesia and antiemetics. And the reason why ERCP is the definition of management is because you need to relieve that obstruction. That's what's causing the picture here, the obstruction in the bile duct. So yeah, that's why. But it's not risk-free. ERCP is associated with a number of pretty serious complications. So pancreatitis, for example, which we'll come on to. Repeated cholangitis, strictures, so any instrumentation can cause stricturing, bleeding, and even perforation, which is quite serious, obviously, and might need surgery. So it's not risk-free. It's definitely something you don't want to take it too lightly, But if ERCP is not suitable for whatever reason, percutaneous transhepatic cholangiography is another thing that you can consider. So you go through the skin. So you go through the skin to cannulate the bile ducts through the intrahepatic bile duct in the kidney itself. You probably don't need to know too much about that, but just that it's a second line if ERCP is not suitable. And sorry, they'll probably need an elective cholecystectomy eventually as well if gallstones is the cause. Okay, so question 4. Let's just put the poll up first and then I'll read it. So, 62-year-old man presents with a 2-month history of progressive jaundice, reports feeling fatigued, itching, dark urine, past medical history of alcohol abuse and obesity, denies any recent travel or sick contacts, has no history of abdominal pain, nausea, vomiting or fever. Which of the following conditions is most likely to be associated with conjugated hyperbilirubinemia? So it's one of those ones where you sort of don't need the stem, you can just go to the question, isn't it? Yeah, I'll give you about 15-20 seconds. So yeah, I think most of you got that right. It's obstructive jaundice. I think I also probably gave that away in one of the previous slides, but conjugation happens in the liver, right? It's the it becomes glucuronylated or something, which makes it water soluble. So obstructive jaundice is post-hepatic. It happens after it's been conjugated in the liver, so such as by a pancreatic carcinoma. So as you can probably guess, we're moving on to jaundice now. So it might look like a pretty busy slide, but I think the main thing with jaundice is just probably to understand the principles of it rather than learning every single cause. So, the prehepatic, intrahepatic or hepatic, and extrahepatic or posthepatic. So prehepatic, generally to do with hemolysis, hematological disorders, spherocytosis, sickle cell, hemolytic anemia, anything where the red blood cells are, being damaged or they're, not great. And it causes an unconjugated bilirubin, okay, because that's this is before the bilirubin has been conjugated in the liver. So again, things like Gilbert's, spherocytosis, sickle cell, G6PD, those are some of the PEDS ones, aren't they? So anything to do with hemolysis, Crigler-Najjar syndrome as well. That's a disease where you can't conjugate bilirubin properly in the liver due to an enzyme deficiency. Intrahepatic, so it's basically anything that directly damages the liver and the hepatocytes, and it leads to both an increase in unconjugated and conjugated bilirubin. Because if you damage the hepatocytes, it reduces their ability to conjugate bilirubin, but you can also get structural damage to the liver that can impair bile flow, causing obstruction, leading to some conjugated hyperbilirubinemia as well. So things like hepatitis, viral hepatitis, autoimmune hepatitis, drugs, alcohol liver disease, NAFLD, PBC and PSC can also cause posthepatic or obstructive, but eventually, they can also cause cirrhosis, and that can cause, hepatocyte damage as well. and also hepatocellular carcinoma. Extrahepatic, so anything that obstructs the bile. If you cannot conjugate bilirubin, so just a question here from Zane. If you cannot conjugate bilirubin in Crigler-Najjar, would that not make intrahepatic? I guess that's a good question. I think it's mainly classed as a prehepatic because you get a purely sort of unconjugated hyperbilirubinemia. So in an intrahepatic, you'd expect a kind of mixed picture of both conjugated and unconjugated hyperbilirubinemia. But with Crigler-Najjar, you're getting that pure unconjugated hyperbilirubinemia. So I guess, anatomically, it might be intrahepatic, but the kind of picture you see on the blood tests with the bilirubin is prehepatic. And then extrahepatic obstruction of bile leads to conjugated hyperbilirubinemia. It can be due to intraluminal causes, like gallstones, as we've discussed, probably the most common cause. Mural, so within the wall itself, cholangiocarcinoma, strictures, or extramural, so pancreatic cancer, pushing down on the bile duct, or sometimes inflamed lymph nodes. So, for example, I think in gastric cancer, you can get invasion of the lymph nodes around the porta hepatis, so the around the bile duct as it exits the liver, which can obstruct the bile duct. Okay, so clinical features going to be yellow, look like Homer Simpson. In cholangitis, they'll also have fever, raised inflammatory markers. Pruritus, because of those bile salts, they can cause itchiness. Abdominal pain. It depends on the cause really of the jaundice, what symptoms you're going to get, doesn't it? So if you have cancers, if you have cholangitis, cholecystitis, you'll get that abdominal pain. If you have obstructive post-hepatic jaundice, you're probably going to have the pale stool and the dark urine, so looking out for those. So basically, it depends on the underlying cause. And some of the investigations. So again, splitting it into bedside tests. Here we've just gone straight for the bloods. There's quite a lot. There's quite a lot in those bloods, but in some trusts, in mine, for example, there's an option when you're requesting bloods just to do a liver screen, like a bloods liver screen, and it just automatically puts all of those on, so you don't need to think about it too much. But maybe just for your learning, we'll probably go through some of those. So why clotting studies is important, because the liver produces a lot of your clotting factors and vitamin K. You can obviously going to do a viral hepatitis screen. Want to rule out some metabolic causes like Wilson's and hemochromatosis. Look at the immunoglobulins, and also autoantibodies in case of autoimmune hepatitis. And then also anti-mitochondrial as well, because of things like PBC, I think it's associated with. And then imaging, ultrasound, CT, MRCP. It depends on it sort of depends on the cause which you're suspecting there. And then diagnostic procedures, ERCP, which can also be therapeutic, as we've talked about in cases of bile obstruction like cholangitis. Or if you think it's to do with the liver problem, then you can do liver biopsy as well. For things like if you think it's a cancer or if you think it's an autoimmune problem as well, histology might be useful there. So next question, I will just put the poll up. So 45-year-old female comes into SAU, very severe upper abdominal pain radiating to the back, nausea, vomiting, history of alcohol dependence and gallstones. Her serum amylase is more than 3 times the upper limit of normal. So what are we thinking? Okay, so the vote so far is quite split. It is acute pancreatitis. That's the diagnosis, but the treatment for most pancreatitis is conservative management. You probably wouldn't do an emergency laparotomy unless you're thinking they've perforated a viscus or their bowel or something. And you wouldn't tend to use antibiotics unless there's a good reason to. So if they're spiking a lot of temperatures, fevers, if they have an infected necrotic part of the pancreas, basically there has to be good evidence of a super added infection on top of the pancreatitis to add antibiotics. But most of the time, it's just conservative management, so controlling the pain, giving them fluids and antiemetics, and also nutrition and dietetics is really important in pancreatitis as well. So why is it pancreatitis? Severe epigastric pain, that's the classic, which radiates to the back, and the serum amylase is virtually diagnostic when it's really raised. So I've said it's more than 3 times the upper limit of normal. That's technically the diagnostic level, but so the normal is about 100. So technically that's above 300, but a lot of the time you'll see it well over 1,000 into the thousands, and that's basically virtually diagnostic. So here's just a little break for your eyes, just a diagram of a pancreas here. You can see the duodenum curving around the head in that C shape. The gallbladder just laterally, and those blood vessels there just coming under the pancreas are the superior mesenteric vessels. Another picture with a few labels. So the pancreas is divided into 5 different bits from the uncinate process, so that kind of hook at the bottom, to the head, and you can't see it here, but there's the neck as well, in between the head and the body, and then you've got the body and then the tail, and then you've got the pancreatic duct, which at the ampulla combines with the common bile duct and then enters the second part of the duodenum via the major papilla. And behind it you can see the portal triad, and behind the pancreas you'll also have the aorta and the IVC as well. So a little bit of anatomy. So moving on to acute pancreatitis. There's a really good acronym for the causes. I get smashed. So yeah, I'm not going to read all of them out, but probably the main ones, the most common ones to know, are the gallstones and the alcohol. By far the most common 2 causes. About 10% are idiopathic, I think, as well, so you don't really find the cause. And another one to look out for is ERCP causing it. So we've got a patient on the ward right now over the last week who's had a really, really severe necrotizing pancreatitis after she came in for an ERCP. So just reiterating earlier, it can have it's associated with pretty serious risks. How does the pathophysiology work? So you get overactivation of the pancreatic digestive enzymes, particularly thinking about trypsin. So you get pepsin from the stomach and trypsin from the pancreas. That leads to autodigestion. So as well as trypsin, you get the lipase, which causes fat necrosis. You get proteases, so trypsin's a protease, isn't it? Can digest blood vessels, leading to hemorrhage. One of the key things about the fat necrosis is that the fatty acids you get combine with the calcium, combine with the calcium in the blood, or that leaks from the blood to form chalky deposits, and that can lead to low levels of calcium because they're all getting used up, combining with the fatty acids. So you can get hypocalcemia with pancreatitis. Another key thing to remember is that you get quite serious fluid shifting and third spacing with pancreatitis. So vascular dilatation, permeability. So aggressive fluid management is a really, really important part of management. And we'll come on to it a bit later, but it can also progress to multi-organ dysfunction, pancreatic necrosis. So does anyone know what these are? Signs, clinical signs. Yeah, that's right. Cullen's and Gray Turners. So the bottom one's Cullen's. That's the central kind of periumbilical bruising, indicating abdominal hemorrhage, and the Gray Turner sign is on the flanks, and that specifically indicates retroperitoneal hemorrhage. The pancreas is a retroperitoneal organ. If you remember the mnemonic SAD, pucker, or acronym or whatever, the P is for pancreas. But yeah, you won't see these in every patient with pancreatitis, but it indicates it's become hemorrhagic, so blood vessels are getting digested and whatnot. So we've touched upon the clinical features, but severe epigastric pain radiates to the back, nausea and vomiting, kind of features of shock. It can be quite severe, can be quite serious. So you'll get that tenderness. You might get some guarding, distension, reduced bowel sounds, Cullen's and Gray Turners, as we've talked about. You might get jaundice if, for example, if the cause is gallstones and the gallstones are also obstructing the CVD, you might also get jaundice. Okay, so investigations, again, stratifying into bedside, bloods, so amylase will be high, or lipase in some places, but I think in the UK it's mainly amylase. So that'll be, pretty high. Key thing about amylase as well is it doesn't correlate with severity, how high the amylase is. So the difference between 1,000 and 4,000, it doesn't mean it's necessarily a worse pancreatitis in terms of severity. So it's really useful for diagnosis, but not for severity stratification. We use this risk scoring on the right here, the Glasgow-Imrie criteria to do that. But just touching on some of the other blood tests, so all your usual ones, group and saving clotting, in case they hemorrhage, you need to give them some blood products. Calcium as well, so as we've talked about, you can get hypocalcemia, and glucose as well, again for the risk scoring. Imaging, probably be a CT, to be honest, or an ultrasound. And then you can also get a chest x-ray if you're worried about perforation, because that's a differential for severe abdominal pain. So the modified Glasgow scale is quite a widely used risk stratification, because pancreatitis can be severe. It can require HDU or ITU input early on. So this kind of aids and guides that decision. So quite nicely. You can remember it by the acronym pancreas. Pancreatitis has all the best acronyms. So partial pressure of oxygen, age, neutrophils, by that I mean white blood cells, calcium, so again low calcium, renal, so you can get an AKI as well because of those fluid shifts that we talked about, so a pre-renal AKI, so looking at urea. Enzymes, LDH and AST, you might want to add those onto the blood tests as well, low albumin, and then glucose. And so the reason why the glucose might be high is because obviously the pancreas has an exocrine and also an endocrine function. So you get enough damage, you can damage those islets of Langerhans, and the insulin producing beta cells. So if you're not able to produce enough insulin, then can lead to diabetes, secondary to pancreatitis. And that's especially seen in chronic pancreatitis, which we won't go too much into chronic pancreatitis, but it's caused by recurrent episodes of acute pancreatitis. So management, as we've touched on in the question, supportive treatment's the mainstay. So just remember that as your default, supportive treatment, analgesia, fluids, antiemetics. They might need an NG tube if they're vomiting a lot. Dietitian input is really key as well. It's super important. They might need Creon as well, because the pathological process is an auto-digestion of the pancreatic tissue. They're not going to be producing as many digestive enzymes. They're not going to be producing as many hormones. So Creon supplementation might be needed, as well as just nutritional supplements like Ensures and milkshakes, or parenteral nutrition if they can't have anything orally. Treating the reversible cause, so if it's gallstones, you can do an ERCP and cholecystectomy. We'll come on to complications in the next bit, and then ITU input. Get that early on if you need it. Alert them, and definitive management afterwards. So I can just see that it's 7 o'clock now. So we're actually nearly at the end. But if anyone does need to go, I'm just going to put the feedback form in the chat, just in case. But it'll probably only take 10 more minutes, to be honest. So complications of acute pancreatitis. The way I would structure this is splitting it into systemic complications and local complications. So systemic, if you kind of think about all of those, all of the criteria in the pancreas Glasgow IMRI scoring thing, you can kind of relate it to the complication. So if you look at PO2, right, that's related to the lungs. So ARDS is a systemic complication, so lung inflammation, effusions. They might need ventilatory support in ITU. Hypocalcemia we've talked about, the calcium reacting with the fatty acids, turning into a chalky deposit. Hyperglycemia, again, we've talked about, so not able to release as much insulin because of the damage to the beta cells. You can get DIC. You can also get hemorrhage as well, so you might need to give them some blood products. Ileus, so severe inflammation. That the pancreas is literally right next to the small bowel and the duodenum, as you can see in the diagram at the bottom. So it can cause an ileus. AKI as well, so the pre-renal AKI, which is why the urea is part of the pancreas score, because of those fluid shifts. And then moving on to local complications. So see with this expertly crafted diagram, you can get pancreatic necrosis, so the tissue just dies, and that can become infected. It also reduces the functional ability of the pancreas. You get abscesses, so that's an indication for antibiotics. You probably see them spiking fevers as well if that happens. And you might get some radiology input to drain it as well. Pseudocysts. So pseudocysts are these kind of packages of fluid, sometimes blood, blood and tissue inside that develop around the pancreas. And typically you want to leave those be for a little while, for a few weeks, because a lot of the time they can resolve by themselves. But if they don't, after, let's say, like five weeks or so, then you can drain them again with radiology. Why are they called pseudocysts rather than cysts? So that they don't actually have an epithelial lining, and a cyst is technically defined by an epithelial lining. You can also drain them through the stomach, actually. So if you do endoscopy, and you can poke a hole through the stomach and drain it into the stomach sometimes. And then hemorrhage, as we've talked about, the autodigestion of the blood vessels. So again, blood products. And this is really just a reference table from Pulse Notes. Pulse Notes is a pretty good resource, I think, if you want to check it out for revision. Just thought this table was quite nice, highlighting the differences between all of these conditions that we've gone through so far. So yeah. Okay, so next question, just coming on to the last couple of things here. Put the poll up. So a 70-year-old woman is referred in by a GP to a gastroenterologist. Epigastric discomfort. She's developed jaundice over several months. She denies any pain. She's also noted some weight loss. On examination, there is no tenderness or mass. On serology, she's recently developed diabetes. What's the most likely diagnosis? Okie doke. So cool time there. So the answer is pancreatic cancer, basically. So the key features, for pancreatic cancer, you can see the weight loss. That's probably the first one. Developing diabetes as well in the context of weight loss is suspicious for pancreatic cancer as well. For a similar reason to the pancreatitis, if you're losing the functional capacity of the pancreas to produce insulin because of damage to the beta cells, then you can develop secondary diabetes from that. Slightly cheeky that there's no mass felt. Sometimes you don't have a mass, but also just the presentation of painless jaundice is a classic sign, which should make you suspicious for pancreatic malignancy. So painless jaundice is probably the takeaway from this. So pancreatic cancer generally presents quite advanced, quite late, has a poor prognosis. Risk factors for developing it: age, so the older you get, smoking, obesity, family history, and also chronic pancreatitis, which can be caused by long-term alcohol misuse. And most pancreatic cancers are adenocarcinomas. because pancreas is a glandular organ, and adeno means gland. I probably wouldn't go into too much detail about the less common subtypes, but most common one's adenocarcinoma. So the cardinal clinical feature is painless obstructive jaundice. And if we go down to the bottom, Courvoisier's law, that's another classic clinical finding. So if you can feel a palpable gallbladder in the presence of jaundice, in the context of jaundice, then that also makes you suspicious for pancreatic cancer. And in multiple choice questions, that's probably going to be the answer. So painless obstructive jaundice, Courvoisier's law, and then other things like weight loss. That's your pancreatic cancer. Sometimes, in some cases, you can get abdominal or back pain if it's become invasive, or locally invasive and advanced. Again, the weight loss. Sometimes you can feel a mass if it's got big enough. Sometimes you can't. And the new onset of diabetes makes you suspicious as well. Investigations. So the diagnosis is usually with imaging, with a CT scan, and then confirmed with a biopsy, so with the histology. Okay. And then after you've made the diagnosis, you need to stage it. So a lot of them will probably be metastatic at presentation. So the CT TAP or CT CAP and the PET CT as well. You're going to do your biochemical workup as well. So the LFTs. Cancer 99's a pancreatic cancer marker. It's not so useful in actually diagnosing it, but it's not really sensitive or specific, but it can be used to monitor treatment. So it has got use. And then some of those other investigations further down the line. So the management, in a lot of cases, it's palliative, but in some cases, so approximately 10% of cases, you can do surgery, and it's called a Whipple's procedure. So you take out the head of the pancreas, the duodenum, and the gallbladder and the bile duct. But in most, and you sort of patch everything up together in this weird new anatomy. But in most cases, it will be palliative. And if for example, if they have jaundice, if the pancreas, if the tumor is obstructing the bile duct, a good thing to do is put a stent in. So that'll be a gastro procedure, putting a stent in to relieve biliary obstruction. Because they might be itchy, they might be jaundiced, might be causing them pain or infections. And then palliative chemotherapy and radiotherapy, symptom control, antiemetics, painkillers. Last question, last short slide. Put the poll in. So yeah, I'm very nearly there. And if you do go early, please could you fill out the feedback form? It's really useful. So 58-year-old man presents with jaundice, worsening over the last 3 months, denies abdominal pain. His stools look pale, his urine's been dark, takes sulfasalazine for ulcerative colitis. He's recently been on holiday to Thailand. He has hepatomegaly, he's apyrexic, and he's hemodynamically stable. So what have we got here? Last question, just have a guess. All right, so cool time there. So cholangiocarcinoma. why is it? So I suppose first of all, looking at the time frame, so 3 months he's had jaundice, so it's a gradual process. It's probably not pancreatitis if it's acute pancreatitis if it's been going on for 3 months. He hasn't got abdominal pain, again probably not pancreatitis then, or cholecystitis. He's got features of obstructive jaundice, so pale stools. He's got hepatomegaly, and he's got ulcerative colitis. So I think the Thailand thing was probably a bit of a red herring, but ulcerative colitis is associated with PSC, primary sclerosing cholangitis, and PSC is associated with cholangiocarcinoma. So first of all, we'll talk about hepatocellular carcinoma. Comes from the hepatocytes. Cirrhosis is the major risk factor. So, chronic hepatitis, NAFLD, or alcohol will put you at risk of hepatocellular carcinoma. Presents late generally, it's got a poor prognosis. Basically, all the HPB cancers are pretty rubbish. And you offer screening to patients with liver cirrhosis as well. So you get weight loss, anorexia, abdo pain, nausea, vomiting. You can get jaundice if it's blocking the bile as well, pruritus as well. Sometimes you can get hepatomegaly and abdominal mass. Investigations, so liver ultrasound. Again, it's a really good first-line investigation for imaging. AFP is a marker which is associated with hepatocellular carcinoma. And then you can do staging with CT and MRI scans, biopsy to confirm for histology. Management depends on how advanced it is. Surgery if it's early disease, it hasn't metastasized everywhere. Liver transplants, radiofrequency ablation, drugs. It probably depends on how advanced it is. And then last slide, cholangiocarcinoma. So it's a cancer originating not from the liver, but from the bile ducts. Majority are adenocarcinomas. And there's a type of cholangiocarcinoma called a Klatskin tumor, which is at the hilum of the bile ducts. So if you see Klatskin tumor in a question, then it's a cholangiocarcinoma. So clinical features, again, the obstructive jaundice, because if it's constricting obstructing the bile ducts, then it's blocking off the bile, isn't it? So the pale stools and the dark urine and the pruritus. Again, weight loss because it's a cancer. You can get some pain. You can get a mass. If it's big enough, you can get hepatomegaly. Investigations again, so do all that workup with the imaging. So CT or MRI, and then confirm on the biopsy. And then, to relieve the obstruction, you can do an ERCP, put a stent in. Management is either curative surgery or palliative chemotherapy. And again, remember Courvoisier's law, because it can present in a similar way to pancreatic cancer with the painless jaundice or the palpable gallbladder. Okay, so just a page with all the sources we've used. Yep. And please, can you fill in the feedback form before you go? So that's the end of the presentation. Thanks for coming along. And yeah, just be honest in the feedback. If there was anything that was that we can improve on, were the questions pitched at the right level? Were the slides too wordy? Were there enough pictures? Was it too long? Just anything you can think of to improve it. And I hope it helped you in your revision.